Hello and welcome to EASD TV. Now, the DELIVER trial outcomes were hotly awaited. They've already been announced, but they've been discussed in more detail at a presentation here at EASD, and I've got three people intimately involved in it to introduce to you. So we have Pardeep Jhund from the UK, we have Silvio Inzucchi from the USA, and Mikhail Kosiborod of the USA. So Pardeep, tell me first of all, what was the purpose of the trial? Why was it set up?
So we conducted the DELIVER trial to determine whether or not dapagliflozin was beneficial in patients with mildly reduced or preserved ejection fraction. So that's an ejection fraction of 40% above 40%. So these patients with heart failure who have an ejection fraction of below 40%, we knew that dapagliflozin was beneficial in those patients, but what we didn't know was whether it would be beneficial in those with a higher ejection fraction. So that's what the DELIVER trial tested. And it looked at a cardiovascular outcome, a primary composite of cardiovascular death or worsening heart failure event. Now, what do I mean by a worsening heart failure event? Heart failure hospitalizations and also urgent heart failure visits. So that's when the patient had to go to hospital, be treated for their heart failure, but weren't necessarily admitted to the hospital overnight. And what we saw was an 18% relative risk reduction in that primary composite endpoint in the patients randomised to dapagliflozin. And that was an amazing result for us because here we now had a treatment for this patient population where our prior trials had all been neutral. We had no therapy that had been shown to be beneficial in this population before to the same extent. So it was a big win for the cardiology community to finally have a therapy for this patient population that seemed to benefit all of the patients. It was very consistent reductions in all of the different subgroups that we looked at.
And of course, we're looking at an increasing number of heart failure patients. Coming down the line, there's an awful lot of people with heart failure coming towards us.
Absolutely, and as you correctly said, there's a lot of patients who are developing heart failure. It's a disease of the elderly. Patients with heart failure with mildly reduced or preserved ejection fraction tend to be older patients as well, and also they're more likely to have other problems like obesity and other comorbidities, which we know are getting more common. And in fact, actually, for the viewers here at ASD, the proportion of patients who have unrecognised heart failure in a diabetes clinic is actually very high and gets higher as your patients age. So we know especially the patients who have mildly reduced or preserved ejection fraction heart failure, a lot of them go unrecognised within the diabetes population. So it's a big problem out there for the types of patients that the viewers will be seeing.
Yes, so my next question was, what does it mean to the average diabetologist?
Well, first of all, as Pardeep said, heart failure is very common across the board, both heart failure with reduced as well as preserved ejection fraction in the diabetes population. As endocrinologists, diabetologists, we don't tend to treat heart failure, but I think we see the patients so frequently that we can sometimes recognize the early signs of, shall we say, incipient heart failure. So the presentation today was about the individual glycemic subgroups in DELIVER, those with normal glycemia, those with pre-diabetes, and those with type 2 diabetes. And what we found was that the benefits of dapagliflozin, which was originally marketed as a glucose-lowering medication, has gone beyond that significantly. The benefit was essentially equivalent in those three subgroups.
So Mikhail, wrap this all up for us. What does it mean?
Well, I think DELIVER trial and its results truly cement what we have that's quite historic, which is the first class of agents ever that are efficacious therapies for patients with heart failure, regardless of what the ejection fraction is. And that's quite remarkable. We've searched for many, many years, and finally we have that first class of agents that can deliver that, pardon the pun, which is a truly efficacious and well-tolerated heart failure therapy across the entire range of ejection fraction, and it's not just that, it's across the range of glycemia, as Silvio just mentioned. It's across the range of clinical settings, whether the patient is in the hospital or recently discharged or ambulatory. It's across the range of age or kidney function. Plus, on top of that, it happens to be therapy that's very easy to administer. It's 1 pill a day. There is no titrations. There is no obligatory laboratory monitoring. So it's going to become, for the first time, a foundational therapy for all patients with heart failure. And I think that's quite remarkable, especially given the humble beginnings where this class began, which is really being developed as glucose-lowering medications.
And there's always a concern about polypharmacy, particularly in people living with diabetes. Can this be mixed and matched with the other kind of drugs that people are taking?
Absolutely. I mean, for glycemic control, it pairs well with metformin, with other standard diabetes therapies, including insulin. For the heart failure therapies, I'll defer to my cardiology colleagues, but it has been shown to be equally efficacious on top of ACE inhibition, beta blockade, etc.
Yeah, it really doesn't matter from a heart failure standpoint, it doesn't matter what other treatments patients are receiving. SGLT2 inhibitors are clearly efficacious and well tolerated regardless of whether they are on a beta blocker or not, ACE inhibitor or ARB or sacubitril valsartan, mineralocorticoid receptor antagonists, or whether they do or don't have implanted device, especially for those in heart failure and reduced EFs that frequently have defibrillators and other implanted devices. So I think the beauty of this class is that if you're someone that's seeing a patient with heart failure, and of course we as cardiologists do, our endocrinology and diabetology colleagues see those patients commonly. Of course, primary care physicians do as well. Bottom line is, if you see a patient with heart failure and they're not on SGLT2 inhibitor,
they ought to be.
They should be, exactly.
That's a pretty simple message. But it also actually brings to mind just how important it is for cardiologists and endocrinologists, diabetologists to work together and not to be siloed, because you were making the point that really you're seeing these folk really much more often than perhaps cardiologists are.
I mean, we see the same patients. We see them for different things, and I think we do have to collaborate. We have been collaborating both in research and in the clinic for several years now.
I think it's very important just to add to that anyone who sees the patient should feel that they can start an SGLT2 inhibitor in these patients. It's not just about doctors and secondary care either, it's about primary care as well. They look after the patients most of the time, and empowering them to start these drugs is important because the drugs are beneficial very quickly. You get a reduction in risk with the SGLT2 inhibitors very, very quickly. So waiting to see either myself or Silvio in the clinic, that's really not what we want. We want our patients on these drugs. They're life-saving drugs. They reduce mortality. Get them on early and get the patient started on top of all the other therapies.
And is there any evidence that putting people on it early is more beneficial than putting them on a later stage?
We haven't done those trials because obviously they're quite hard to do if you imagine all of the different combinations that you could start with. But what we have done previously is we've published an analysis, which was, I suppose, an exercise in trying to see what would happen in terms of the benefits if we started these different drugs in different sequences according to the benefit that they showed in the trials. And actually, we showed that you get your biggest bang for your buck, as it were, by starting an SGLT2 inhibitor and an MRA, a mineralocorticoid receptor, first off, rather than the traditional method of starting an ACE inhibitor and then a beta blocker, then an MRA. So actually, there's some evidence or some thoughts to suggest that actually starting these things quicker is better for our patients.
And there are some studies going on now in the hospital setting, so to actually not wait until the patient is discharged, but prior to discharge to starting these medications.
We should say that Deliver had some of those patients in the trial as well, or who had been recently hospitalised, and the benefit was the same in that patient population as it was in the overall population. So I don't think there's too much hesitancy now to start these drugs in hospital that there was when they first came out. I think we were all a little bit worried about it, and there was a bit of guidance about not doing it, but I think that has now disappeared as time has gone on and we have more evidence.
Yeah, no, I think also as far as the timing is concerned, it's important to keep in mind that heart failure is a progressive disease that needs to be treated aggressively, and there is really no reason to wait. And in fact, the other piece that's important here is that unlike many other treatments in heart failure, these agents are not just beneficial when it comes to reducing the risk of morbidity and mortality, but also make patients feel better. I mean, heart failure is a clinical syndrome that's characterized by debilitating symptoms. Patients are short of breath, have exertional intolerance, they can't go on doing things they would like to do. These agents actually make patients feel better and be able to do more. And that's another compelling reason to do it earlier and be more aggressive about it than kind of taking a wait-and-see approach.
So I've got a really strong message from all of you that you don't have to be a fancy specialist. If you see a patient and you're in primary care, these drugs are just as much for use in primary care as they are anywhere else.
Absolutely. I think the primary care doctors have been using SGLT2 inhibitors for a lot longer than cardiologists like Mikhail and myself. So actually they're very comfortable using these drugs. As Silvio said, they started as glucose-lowering drugs, and so they've had more experience, I think, than we have had with them. So absolutely. And as was mentioned, their safety profile is excellent. It's really much better than almost every other drug we have in cardiology.
Especially in a tenuous patient population like a patient with heart failure. We were initially concerned about decreases in renal function because these patients are all on heavy-duty diuretics, but they're amazingly safe.
Yeah.
So just a final thing from you, Pardeep. What's next? Is that done and dusted, the end of the story, or are there more trials to be done?
There are a few other trials going on with SGLT2 inhibitors, as Silvio said, in the setting of hospitalised patients, to look at the patients earlier on in their hospitalisation. And then there's also some trials going on in patients who've had a myocardial infarction, a heart attack, to see if they're beneficial in that patient population, because we can think of that as almost a precursor to heart failure. So maybe starting them at that earlier stage might be beneficial, the same way as we saw with ACE inhibitors. So more to come, I think, in the years coming ahead.
It's because you cardiologists have been so successful, of course. Saving people from heart attacks and the heart failure comes later.
Absolutely.
Yeah. But thank you so much, all of you, for being with us. So a really good piece of news there, which I know will be received very enthusiastically by those in primary care in particular, but also principally those people living with diabetes. Bye for now.